Good morning, Dr. Baran.
Morning.
It really is a pleasure to be speaking with you here today. My name is Ross Lavine. I'm a fellow currently at Baylor College of Medicine. I'm doing critical care, and I'm really excited to be talking to you today.
Thank you. I'm David Baran, section head for heart failure transplant MCS at Cleveland Clinic, Florida. I'm delighted to talk to you as well.
Awesome, awesome. Well, nice to have you. So first question. So you were instrumental in the development of the SCAI shock stages. How have you seen these stages impact clinical decision-making and outcomes across different disciplines, especially in cardiothoracic surgery and critical care?
Well, thank you. So, we started the SCAI staging initially to solve a clinical problem. So I'm a clinician first, and it always occurred to me that we had no common way of describing shock. It was highlighted actually by a case that I had of somebody where they begged and pleaded, can you send me this patient right away? The patient's so deathly ill. And so I actually had our team available with the wet circuit, surgeons sitting there, all of us, and like usual, transport is always delayed. Anyway, the patient comes rolling in, this is back in 2018, and it was perfectly fine. But to the other site, this was the worst patient they had ever seen in their life. I'm not sure what they were thinking, because the patient looked to our team perfectly fine and certainly didn't need ECMO. Right. Needed critical care, but not that. Right. And then that started a discussion saying, gee, should we make some sort of a framework? And then SCAI shock evolved. And so since that time, it's been really neat to see that it's been taken up by a variety of disciplines, particularly in critical care. And I think it just like the New York Heart Association class for chronic heart failure, it filled the need to be able to say how we all talk about the patient the same way. And there's certainly some subtleties, and it's been criticized because it's not super granular. You can't say, okay, the lactate is 2.1, it's this or that. Right. But the simplicity of it has helped. So I think there's still more work to be done, but people in general are talking about stages of shock. And I think the fact that also people think about the gradations of shock and the prognostication, that's been helpful as well.
Right. Awesome. What are some of the biggest challenges you see in fostering cross-disciplinary collaboration between disciplines such as cardiology, surgery, and intensivists in the management of cardiogenic shock?
That's a great question. So, the problem is really one of having a true heart team, and so on paper, it sounds pretty simple. Right. But the problem is that all of us as physicians and otherwise as practitioners and clinicians, unfortunately, ego can tend to get into the way. So in some specialties, for example, maybe cardiothoracic surgery or intensive care, each tends to think that they are, the one. And the problem is our teams really work when you have really mutual respect and communication. And so, the challenges are when you have, for example, cardiothoracic surgery, thinks, well, the OR, I know this and that. Why is my cardiologist trying to place ECMO or these other things? And so I think the keys are mutual respect and really good communication. And particularly also for some of the other team members that aren't always considered to have the same voice. So in our team, our nurse practitioner, our RN at the bedside has equal ability to speak up and point out what they think. That's really, really critically important. If you have people that feel sort of afraid to speak because, they think of it as a hierarchy, that doesn't work. So part of the team leader is to empower all the members of the team that their voice is valuable and desirable.
Yes, absolutely. And I think that's one of the beauties about ICU. We just work really well as a team, but really involving all specialists in the care of the patient can definitely lead to great outcomes. Dr. Baran, how do you envision the role of standardized shock teams models evolving, and what key metrics should institutions be tracking to truly assess success in these programs?
That's a great question. So I think, as I consider that question, I think, should it be standardized? And so if you look, for example, at the publications from Inova, Utah, Canada, each of them has similar guidelines where they look in general to phenotype shock and then decide what devices and things are appropriate. But I think that it's really hard to standardize because every house is different. So I use the analogy that If I come over to your house and look at your cupboard, where you have the salt, the sugar, and the spices, maybe all different, but they all sort of work. Everybody has something that works for them. If you look at my desk, it's quite a mess, but I know where all the parts are if I needed something. And so I think what's important is that people have a idea in their center what works. So in their center, for example, if they have X, Y, or Z device, well, their protocol is going to look very different than if you're in a place with transplant bad, perfusion is sitting there all the time, maybe very different. So I think writing it down on paper and really understanding is a good guideline. But of course, when push comes to shove and patient's super sick, very few are going to be pulling out an index card to say, what do we do next?
Right.
But if by preparing, by having had that idea, then basically when patients are sick, you can think in your mind, okay, what do we want to do?
Right.
So I don't think that we'll end up standardizing them per se, but I think the idea of sort of thinking in advance is helpful. I think that's been the biggest advance.
Awesome. Well, thank you for that, Dr. Baran. Another question I have for you. So for early and mid-career clinicians like myself, looking to lead in the field of shock management, what advice would you give for getting involved with national societies like SCAI and CHESS and driving meaningful change?
It's a great question. So I think the key issue is three things. Focus, that one really has to decide what they are interested in. It's very difficult to do everything and be involved in every area all at once. So one focuses on a particular area. Then persistence, so that one, for example, is involved in shock, then really raise your arm, be willing to volunteer when things are being done in a particular area. And then delivery. So that many times there are folks where they're volunteer for everything, but then, well, I'm on service, I'm this and that, and excuses can multiply faster than rabbits. But if one is persistent, I know for myself, I've been involved in some societies and have been able to work up the ranks of those societies because if I say I'll do something, they know who are the people who have the big name, but who are actually able to do the work.
Right.
And so for a younger person, that's really key. If one says, for example, hey, I'll write on this task force or do this in the beginning, maybe the assignments are small, like grading abstracts or something minor, but they said, gee, this person delivers, or gee, somebody's out sick, can you give this talk? And they give an awesome talk and there's no issue. If this is a reliable person, that combination of saying, well, this person's really interested in this, they deliver on what they said they'll do, and they're willing to start at the lower ends of things and then build up, I think is important. You also have to be involved in societies like SCAI and some of the others that reward and want to bring in young people. There are certainly some societies where I would say it's the old person's club and it's the same people over and over. And I think that kind of thing is disappearing. But societies that are more enlightened want and welcome the young folks to be involved because you are ultimately the future.
Thank you. Thank you so much for that, Dr. Baran. And the last question I have for you. So in what ways do you think we can improve the outcomes for patients with cardiogenic shock?
Okay, so I think that, to my mind, as I look at all of this rapid evolving set of data that is available, you still by and large see 50% mortality in everything. We celebrate when we have 5% reduction in mortality with devices that are expensive, that are fairly toxic. And certainly that's good, for example, in AMI shock. But I think the problem is that we really need to move it backwards. We need to look at early states. So I'm working with devices trying to locate shock at an earlier stage. It is the patient that's in SCAI B or that is just starting to slip into SCAI C that probably the easiest to intervene on. And I always use the analogy of fire. So if you have a small wastebasket fire, it's relatively simple to put out. When it spreads, it's much more difficult.
Yes.
And then, the extreme example, SCAI would be like a forest fire, where even in the real world, you can devote any amount of resources you want. It could be in any area, and yet you literally just have to wait till the fire burns out, and relatively powerless. Yeah. That's oftentimes how we feel when dealing with a patient that's critically ill, SCAI. We try everything, we want to just do our best to save the patient, but oftentimes you're not successful despite maximal effort.
Yeah.
And you realize, gee, if I had caught that patient 24 hours before, it might have been actually a much less invasive intervention. Right. So I think that's where we need to push.
Awesome, awesome. Well, Dr. Baran, it was really nice speaking to you. And, you know, I really appreciate you taking your time out to speak with us.
Sure.
And thank you very, very much.
Wish you the best of luck in your career.
Thank you.